Time to treatment failure, it may be a more pragmatic endpoint than PFS, because time to treatment failure includes things like discontinuation for toxicity or for other reasons the patient may choose to stop therapy. The real drivers of why patients start or stop therapy are included in that, including death or disease progression. They're all wrapped into one. So it really is a much more, I think, pragmatic, digestible endpoint for patients. I think the time to treatment failure, it is a sort of a combination endpoint of progression enough to take someone off therapy, also toxicity that was not manageable for patients, or patient preference. So it really kind of encompasses all of the pragmatic different reasons someone would stop a therapy, again in a very pragmatic way that I think we can take home, and that will reflect on our patient care in the clinic. It's hard to comment on the meaning of the overall survival data we've seen so far. I think it's just not mature enough. The trend, the confidence interval leans more towards favoring, the afatinib. However, it may be underpowered to show significance. Objective response rate is something, again, we teach residents and students not to go by. It really means how a scan looks, how much better a scan looks compared to before. The primary endpoints in palliative therapy for cancer are survival and quality of life. However, in lung cancer particularly, the response rates can be meaningful because patient pain, for example, bleeding, impact on breathing, if there's a bronchial tube being blocked, really can vary directly with the size of a tumor. So if you have a good response rate or a rapid response, it can meaningfully translate to symptom improvement in our patients fairly quickly.